Hello and welcome to the latest episode of the Melbourne Athletic Development Podcast. Jack?
How are you, John?
I'm well, mate. Today, you want to discuss an area that you've been exploring, obviously, for the last, few years, but it's starting to expand into some interesting areas. And you wanted to kind of give us the opportunity to navigate where you think your ideas around this are. And obviously in a recent podcast, we did something similar where I spoke about some training elements that I felt were I was exploring, and you wanted to do a similar thing, but for a concept and an idea in a clinical sort of realm. And I know that before this, you sort of said, well, just so everyone's aware, this is this is not a fully formed idea. You do want feedback on it. You do want to explore it, and you think it's pretty solid, but you're not 100% sure if you're exactly on the right mark. And that's to do with pain perception.
Yeah, and more specifically, neuropathic pain, and even getting more specific, pain associated with nerve root compression.
Okay, let's get into that. So what exactly what are you defining neuropathic pain as?
Okay, so I'm defining neuropathic pain as pain generating from nerve tissue due to some type of compression, injury, or some other type of pathology. Yeah. So the two most common ones that people would think about is some type of nerve root compression, i.e.
which we commonly see with, like lumbar spine. Correct. Or even cervical spine particularly.
Typically associated with some type of disc pathology, like a disc herniation that causes compression and inflammation of the nerve root as it exits the spine, the vertebrae, and then manifests as symptoms typically in the legs or in the arms, depending if it's the cervical or lumbar spine, but obviously can happen at any segmental level.
Yep.
So there seems to be a lot of confusion.
What was the other type? You said nerve root compression. What was the
other? Sorry. So that's the other one. The other most common one is some type of peripheral neural entrapment. So like a good example of that would be something like carpal tunnel syndrome.
Yes. And that's probably the most common example that people are aware of. It gives you those neurological symptoms. Correct. In a peripheral kind of approach.
Yeah. So it's, I guess, very similar to a nerve root compression, but the compression or entrapment happens somewhere further along the periphery, and the symptoms will manifest slightly differently. And we can talk a little bit more about that. There's obviously different types of neuropathic pain. Like a good example would be something from like herpes zoster, shingles. So that will cause compression, irritation of a nerve, depending on what segment we're talking about. Typically that happens in the thoracic spine. And there's obviously a lot of other different types of potential neurological conditions where you can get similar types of neuropathic pain. So it's something that we spoke about a few weeks ago, actually, in a clinical meeting. We were talking about the presentation of someone with a nerve root compression and thinking about pain. And typically when you think about nerve root compression and pain, people think about radicular pain. And it's something that we typically think about as described as that very sharp, lancinating, quite like almost sickening pain that goes down the leg.
Particularly we notice it a lot with the leg. People will say they're getting symptoms in their ankle, foot, in a particular pathway.
Correct. And it's worth noting here that when you do have a nerve root compression, you actually may not have radicular pain. It actually doesn't seem to be that common.
Yes.
In saying that, you do get a lot of people who will present with lower limb symptoms.
Yes.
Now, it's interesting when you look at radicular pain. There's actually been quite a bit of research done from a few different research groups where they've got a group of participants. They inject some type of chemical or mechanical irritant at the nerve root to see where the symptoms manifest. Because a lot of the time when people think about radicular pain, they think it will manifest within a dermatome. So again, for clinicians out there, they'll be familiar with dermatome maps that show the innervation.
Skin region, yeah.
Correct. The particular area of skin that's predominantly supplied by a particular nerve root. So like a good example would be thinking of something like L3, predominantly through that anteromedial thigh region. But when you look at studies that have looked at trying to irritate the nerve root and see where the symptoms manifest, it's all over the place.
Okay, so it doesn't tend to follow those very clear, say, dermatomal patterns?
Not at all. No, not at all.
That's very interesting because it's something that you have in your mind that when you start to do, like I had a patient the other day where I was concerned that there was potentially some neurological manifestations occurring from what I thought was a disc pathology, and I wanted to go through some sort of neurological assessment. And I'm following these dermatomal patterns, but you're telling me now that I'm an idiot, and that's not actually doing what I think it's doing.
Well, the reality is so many people follow those particular guidelines, but when you actually look at the research of where symptoms can manifest from a particular nerve root, it's all over the place.
Yeah.
So like if you look at, there's a really well-done study in 2019, I think it was Furman was the author, where the different patterns of symptoms for, say, L4 literally was like the whole leg. It could be anywhere through the anterior leg from the hip down to the ankle, anywhere through the posterior leg. And pretty much when you look at the lumbar segments from L3 to S1, there is massive amounts of overlap and no real consistency with going, oh yes, L3 is predominantly through the anteromedial thigh, or L4 is predominantly through anterolateral lower leg. There's a lot of overlap. A lot of people have questioned this to think of like, well, whatever happened to that kind of classic radicular pain where it just goes down through the back of the leg or within a particular line. But when I was looking into the studies that had looked at exploring where pain can be experienced, one of the things I noticed is, one, they either never got the patient to describe particular descriptors of pain. So like, was it more of like your deep, dull ache? Was it more of like that classic radicular pain of, say, like a sharp lancinating pain? Was it more of like neuropathic type pain when you think of, say, numbness, burning, tingling? And then I actually came across one study that did do that. And this study, again, had the same outcomes where the pain in the lower limb, when looking at lumbar segments, was all over the place. But they actually did look at descriptions of different types of pain, and they categorized them into either neuropathic, intermittent, continuous, or affective. And what you saw is they actually, in these studies, they include all these different types of pain. So they're not actually just looking specifically for radicular pain, that sharp shooting lancinating pain. It's any of these symptoms. So straight away that started to make me think, okay, is one of the issues here with a lot of these studies and our understanding of neuropathic pain from a nerve root compression is we're not separating out radicular pain in terms of that classic radicular pain from other types of neuropathic pain. And this is what started to make me think about, well, when you get a nerve root compression, what types of issues do you see? Well, we see changes to the dermatome. So that is that particular area of the skin predominantly supplied by a nerve root. You might see changes in sensation. And like they're the classic symptoms that make you sometimes think that this might be a nerve root compression when you think about tingling, numbness, burning sensation. You also get changes to the myotome, i.e. the muscle group predominantly supplied by that particular nerve root, typically associated with weakness. You can also get, it's one that we don't often think about, is sclerotome too. So the particular bone, and specifically the periosteum, that's predominantly innervated by a nerve root.
What are the symptoms that someone would get relating to sclerotome?
So the sclerotome, and this is where we actually need to talk about this also with the myotome, the sclerotome will typically manifest as pain. And bone or sclerotome type pain is more that deep, dull ache. But we also have to understand that too, that the myotome, i.e. the muscle, can also produce pain. And we also know that muscle has a very distinct type of pain pattern. Again, it's that much more continuous, deep, dull ache. The other one that people always forget about, and we talk about it on this podcast all the time, is the deep fascia. And I think it's important to describe deep fascia versus superficial fascia, because the dermatome, i.e. the skin, is related to the superficial fascia, which will create some of those neuropathic type pain symptoms, where the deep fascia has its own very distinct type of pain pattern. That is, it's typically much more sharp and mechanical, sharp shooting pain. And it can actually be also related to heat pain, so like thermal descriptors, burning. But it's interesting when you look at some of the research from Schilder in the 2010s, the other thing that's very evident with pain when you irritate the deep fascia is the intensity is much higher than the muscle or the superficial fascia. And it's interesting to note some of Carla Stecco's work. She actually did a more of a narrative review or a literature review describing what's been called before the fasciotome. So when you think about the nerve root, we know the dermatome, we know the myotome, we know the sclerotome, but some of the work that she cites talks about the fasciotome, the particular portion of the deep fascia that's predominantly innervated by a particular nerve root. And this is a term that was used previously from Frank Willard's work, who did a lot of research into looking at the anatomy of the thoracolumbar fascia. He talks about research that's been done in animal models showing that in rats, when you look at the thoracolumbar fascia, the thoracolumbar fascia is predominantly innervated by a particular nerve root. And when you think about the deep fascia, it is everywhere. So when you think about the lower limbs, not only are we getting innervation from our lumbosacral plexus to the muscles, to the skin, to the bone, we go also to the deep fascia. And what Carla proposed in her paper was that the fasciotome is probably a better indication that describes the patterns that we see with that true radicular pain, because we know that deep fascia will generate that sharp, shooting, lancinating pain. The intensity of pain from the deep fascia is higher, particularly when you've got chemical irritation, i.e. inflammation. And interestingly, when you look at the deep fascia typically is organized within these longitudinal planes. And it actually probably provides a better indication, and this is, again, at this point, very much just a theory.
This is the part where we say we want people to be open to understanding this is an idea that's developing.
And by all means, for people who are listening to this and going, this is all wrong, and then you want to point out some of the limitations to it, by all means, get in contact with us to let us know.
As we said last time, that is the point of this, though, is that you're navigating this with the understanding that we don't really fully understand these pain-generating features.
No.
And so it's worth exploring potential sources that are not at this stage completely elucidated.
No, and look, this whole theory or hypothesis that I've come up with is just trying to look at the research in this topic, seeing where some of the limitations are and trying to make sense of it. Because, and just to go a little bit further than talking about the deep fascia, it may be that, what Carla proposes is that each segment innervates a particular portion of the deep fascia that goes more on a longitudinal plane. So when you think about your classic radicular pain in that posterior leg, that may be more indicative of predominantly innervated by the S1 nerve root. If you look more within that lateral, which again, a lot of radicular pain it will often be more of that L5 nerve root. If you look more within that anterior compartment, or the L4 nerve root. And if you look more within the medial compartment or medial chain, the L3 nerve root. And we can look at a similar mapping within the upper limb for C7, C6, C5, C4. And so when I started to put this together, it started to help me think of making more sense of, well, are we seeing all these mixed patterns of pain associated with a nerve root compression in research because they don't differentiate these different types of pain that may be associated with different types of tissue? And again, this is all speculation, but I think it'd be interesting to see if further research comes out to look at this, of when we start to then think of classifying different types of pain as being more that neuropathic pain, when you think of, say, numbness, tingling, burning, that typically is more associated with symptoms within the dermatomal distribution. When you think of more that deep, dull, continuous ache, that may be more associated with the particular muscles or the periosteum predominantly innervated by that particular nerve root. And then if there is that classic type of radicular pain, because understand that when you have a nerve root compression, you may have one or multiple types of different types of pain descriptors, or none. Then when you get that classic radicular pain, it follows more that deep fascial plane associated with that particular nerve root. And again, at this point, this is something that's all purely speculative, but I think it really helped me to understand then that when you, and this is probably something that we both talk about, when you see someone with a nerve root compression, you do see a lot of variation in terms of the type of symptoms they present with, i.e. the classic ones in terms of weakness or changes in sensation or reflexes associated with dermatome or myotome changes. but also then with the pain presentation, because you do occasionally get those classic types of radicular pain, the sharp shooting lancinating pain. And that's probably more indicative of the fascia tone being more affected from that nerve root compression. It may be more the burning.
When you say like this is undeveloped, is this something that I haven't read that paper you mentioned from Carla, but is this something that she started to think and proposed, and what? Just so I even understand, like what parts have you added in your estimation?
So she has proposed the fascia tone. Well, she hasn't actually proposed it. That's actually been proposed by previous authors who have done research looking specifically at the innervation of the deep fascia, like the thoracolumbar fascia being predominantly innervated by one nerve root. And then probably more proposed by Frank Willard. And then she proposed this to try and help explain some of the pain patterns that you see. I've probably tried to take it a step further to go, well, it's never that clear though, where it's like this clear type of pain within one particular plane. But my suggestion or my hypothesis is that the limitation is people not describing what type of pain someone's getting. So when we think about the particular pain descriptors and you differentiate it or group it into that more neuropathic, intermittent, continuous, that may give us a more of an indication of, oh, okay, and as I was mentioning before, that neuropathic pain probably does follow more the typical dermatome pattern, as opposed to the classic radicular pain probably follows more the fascia tone. And then for the deep dull ache, that probably follows more the myotome or the sclerotome.
And in your mind, does that change how you're addressing this?
Yeah, it's something I've thought about. And I guess ultimately when you think about treating someone with a nerve root compression, you do want to try and reduce those symptoms within the limb. You want to try and quote unquote centralize their pain to some extent. I do think it provides some indications about how you may be able to reduce some of the pain by treating different types of tissue.
Well, this is the question. Do you think that treating the peripheral tissue will have the effect on what is probably a reasonably centrally driven pain generator?
So in short, yes. And this is some of the more recent research that's looked at when you get neurogenic inflammation, because remember, a nerve root compression, if you just compress the nerve, it might cause some types of bursts of pain, but it won't cause your classic type of radiculopathy or radicular pain. When you get neurogenic inflammation, you see a cascade that then changes the peripheral tissue that nerve root or nerve innervates. And this is something that I think people don't quite understand because we tend to still have that separation of different systems, i.e. the neurological or the central nervous system to the peripheral or the peripheral nervous system to the soft tissue system. But you actually do see changes. So this occurs because of that irritation of the nerve and inflammation that then alters signals and potentially even chemicals within the innervated tissue that you then start to see changes within the tissue itself. And I think this is actually a really important thing for people to understand for lots of different types of pain conditions, particularly when you think about long-term chronic pain, where a lot of people associate that with central sensitization. That even in patients who are predisposed to central sensitization because they have certain psychological or emotional traits, that can actually still manifest as changes within the peripheral tissue as well, because the changes within the central environment with regards to inflammation or changes in neurotransmitters that again might manifest changes in inflammation in the immune system do manifest within the actual musculoskeletal system as well.
With that in mind, do you think that that's where we're going with the research around these type of pain presentations? This reminds me very much of, the change that happened, particularly with imaging around, say, muscle strain injuries, where it went from being the grading based on, say, the size, to being much more related to, okay, what tissue is actually affected. And then it became a grading system of, and particularly if you look at, there's a few, but obviously things like the British Athletics classification, they're trying to say, well, it's this size, which gives you the 1, 2, 3, 4 sort of grading. it's this structure which gives you A, B, C, and then that gives you the opportunity. Do you think that we potentially will end up with a similar kind of grading for neuropathic pain where it's, one is that it's, as I said, like a consistent, or intermittent or whatever it is. And then two is like, we think it's the sclerotome. And then it's, that's the ABC version of it. Do you think it would be almost worthwhile defining in that way so it gives clinicians an opportunity to say, okay, well, this is a 2C neuropathic?
I actually haven't gone that far, but it's actually an interesting point to make of when you start to think about the different tissues innervated. If you've got more tissues involved in terms of the pain presentation or changes in sensation or strength, does that mean typically a worse outcome or a longer term management?
I'm going even at a really basic level of just kind of
just
classifying it to make it easier to understand potentially what's driving this, because I think that's the big issue, because we don't, as you said, we don't have a very clear classification, so they all get lumped in together as like, this is just neuropathic pain.
Yeah.
Would it actually make it a hell of a lot easier? Because whilst managing, say, strain type injuries has become a little bit more complicated because people are very caught up in what structure it is, it probably has made it a lot clearer, particularly the ones that like you have to be more diligent with, the ones that you can say, well, okay, well, that's epimysical, so, and it's small.
Yep.
We're happy to kind of push this one along, versus something that clearly involves tendon structure. We need to go a bit slower. Potentially, this gives not exactly the same, but it's something similar where it's like, okay, well, this is more dermatomal. Yes, it's there, but it's not really affecting too many of the sensory inputs, and we think it's not going to adjust, their motor output, and it's not going to cause any of that real heavy lancinating pain. So we can kind of gradually build them through a lot quicker than maybe someone who does. And on the surface, that's obvious. It's kind of like saying someone who strains their hamstring and they're like struggling to walk, versus the person who goes, I felt that pull, but I'm walking around with 1 out of 10 pain. It's pretty similar. Like someone who's got that lancinating pain is hobbling, versus the person's like, I've got some awareness in my thigh. They're different things, I understand, but it gives you much clearer indication as a clinician of like, okay, I know where this is graded. And I think it's almost like how you can communicate with the patient and say, this is the type of, you are getting, whether it's discogenic in origin, but you're getting this neuropathic pain. It seems to be in this classification. These typically take X amount of time before we see the changes. You can be a bit more aggressive with, the general activity that you do, and, X, Y, Z.
Look, probably. And just thinking through in real time, one thing it made me think of just then, as you asked that question, is if someone has a nerve root compression, but they only have like that deep, dull ache pain because the sclerotome's involved, it makes me actually think of maybe not jumping too quickly to think that's not neuropathic. Because a lot of the time people come with back pain, they come with very sort of vague, deep pain in their thigh, and you think, it's probably more like a somatic referral or myofascial referral pain, but maybe you shouldn't be so quick to make that judgment. In saying that, when you look at the research of looking at descriptors of pain, the biggest one they get by far is more like that tingling numbness, classic neuropathic pain anyway. So look, I guess just even thinking through it clinically, most of the time when someone comes in with a nerve root compression and they've got some changes in the dermatome, but they've got, like, say, no weakness, I typically see them as getting better much more quickly, as opposed to the other end.
And I think that's the communication that you have with the patient anyway. You say, like, as you said, it typically, and I say this all the time to patients, they say, I'm getting some pain down my leg. And even though it might be trailing, it's like, okay, is it consistent? Are you getting any of these other symptoms? You do your neurological assessment. You see whether the sensory input is different. We're lucky enough to obviously have equipment to do force output testing. We look at those things with some objectivity and say, okay, like, you're not getting significant changes to your motor output. You're not getting significant changes to your sensory input, whilst you have awareness in this region, and it does appear to have some sort of neuropathic origin. It's not what we would consider a long-term rehabilitation process. You will recover and you will have a good outcome.
Yeah. And look, the other thing I think of too, when you compare it to some of the muscle injury classifications, is what where are the limitations of those classifications as well? Because I
Yeah.
think of like the British Athletics one, where if you look at the use of that and as indication for prognosis, there's not a lot of really good research out there. Like there's probably some indications for when you look at, say, central tendon or like more like complete tendon or free tendon involvement, that there's a longer outcome for management.
Yeah, but I think it's more about not necessarily the middle ground. It's more the extremes.
That's a good way
And I
to put
think
it.
that's what has given me as a clinician. I find like I have a lot more confidence now in the extremes when you do have imaging done and you're like, okay, like for instance, in the lead up to a major competition, recently I had an athlete come to me who wanted to get back from an injury within 2 weeks. I said, okay, get a scan done. And it came back and it said they had a grade 2 epimysial injury in a region that I wasn't particularly concerned with in their hamstring. And I said, okay, like we can push this. And, we did a really intensive rehab process. They were doing loading, twice a day, all that kind of thing. But they got back and ran, pretty much at the full intensity, or they did run at full intensity, and it was 13 days after their so-called injury and they ran at 100%. I would not have actually probably wanted to do that if it involved more of the actual contractile element of their muscle tissue, or if it involved tendon, it was like there's absolutely no chance.
Sure.
And the risk is probably just way too high for us to consider this. So to me, it's given me more certainty, not necessarily to say that my management is that different, but just to actually almost go like, no, that's no chance, or there is some probability of this. And I think it's the same. It's not the same, but it's something that we could consider for these type of pain presentations.
Well, the other thing I think of then too, with going back to neuropathic pain or like it's nerve recompression, is why do some people get radicular pain, classic radicular pain, and why some people don't?
Yeah.
Because that seems to be something that no one really knows the answer to. And like maybe you can start to understand it if you look at the actual cross-sectional layer of your nerve, and maybe there's certain portions of the nerve that innervate predominantly the superficial fascia or the deep fascia of the muscle. I don't know.
Or do you think it's the other way around, that the peripheral system is influencing what the presentation is?
And I was going to use that as an example because classic radicular pain doesn't seem to be that common, but I actually saw someone last year who very much presented with very classic radicular pain that was anterior.
On their thigh.
On their thigh. And like that classic sharp shooting, lancinating pain, couldn't sleep, couldn't find any comfort, like quite debilitating for this person. Something that really stood out to me with looking at their past medical history of like, why did you get this? Because it just came on like city onset. Yeah. Is they'd had quite severe knee injury and surgery before. So it made me think of, okay, and interestingly, they had signs when you looked at, say, changes in their dermatome and myotome, they were associated with their L4, which, when you think about the fasciotome, is that anterior chain. And it made me think of, well, is their predisposition to getting nerve root compression at that L4 and getting radicular pain related to changes within the deep fascia within that plane? Again, this is all speculation.
Of course, but as you said, if you've had surgery to your knee, it's going to affect the deep. Well, it's going to affect all tissues. Like that's the thing. Complicating factor is it's going to affect.
This is true.
All of those tissues.
This is true.
In that femoral region.
Correct. Yeah, no, and maybe it's not a predisposition to one particular nerve root.
But that's why it's funny you say that though, because I actually, and it's your influence heavily on this, but I notice how much fascial pain people get post-surgery. And that's clear, obviously, because those layers particularly going to have a lot of stasis and you get those adhesions. And so it's always really interesting, particularly with knee surgery, how often they'll present and they'll say, I'm getting knee pain, I'm getting... And then you have a bit of a feel through their anterior thigh and palpate that and you go, well, actually, this is not moving well, and you do some friction type treatment and like, oh, that's way better. Like the improvements, from 5 out of 10 to nothing. And you're like, okay, well, that's more than what just you would expect.
And like using, say, an ACL reconstruction as an example, it's so common I see too, where they're obviously getting so good with surgery and using keyhole surgery which I find typically doesn't cause too much problems in terms of, say, scar tissue or change the deep fascia. But that classic scar at the superior tibia, that they make as they drill through the tibia, you get so much scar tissue fibrosis between the skin all the way down sometimes to the deep fascia and the periosteum. Or the other one I think you see a bit more too is now they're doing the lateral tenodesis, that you get a lot of issues through that lateral compartment as well. Look, clinically, I think that makes a lot of sense. And, we've talked a lot about this before, but thinking about particularly when someone presents with that kind of non-specific pain, of how that can be associated within a particular plane, associated with prior injuries. And like the great example obviously is because so many people have had some type of ankle pathology from an ankle sprain to potentially like an ankle fracture. And that depending on where the particular pathology is, you see a common manifestation of symptoms around their knee or even further up their leg because it changes within the deep fascia and how that affects the fascial mechanics. And so, thinking about something like radicular pain, maybe there is some association to that. But I mean, at this point, it seems like there needs to be a lot more things done to understand why some people get that classic radicular pain and why they don't. And not to mention whether this is actually related to the innervation of the deep fascia. Yeah. So, I'll be interested to hear if anyone has any thoughts on that and whether they think it makes sense or whether it doesn't.
Yeah, I think it's a good thing to think about because pain, even personally, I feel like pain often, because there aren't there are some, but it's not as well defined, I think, as what it needs to be clinically so that we can start to think about, as you said, what structures may be involved. Because it is very, very clear that, and it's funny, you're making me think of, like, we put this into some of the presentations that we've done actually with our education courses. And it was, I remember speaking with you about it when we did it, about people having a very basic understanding of, say, healing times for different tissues and how different tissues, we all know this, like obviously we talk about things like tendon having, in terms of the cell turnover being a little bit slower than something like muscle tissue. And there's often discussion around the idea of how much innervation it has, what the blood, like how much blood flow that it receives, what's the perfusion, all of these different factors. What the communication pathway is, is it through mechanical tension? Is it through other means? And what effect that has on its ability to respond to the stress that it's applied upon it, whether that be some, damage that's actually occurred to it, whether it's even, training stress or rehabilitation exercises. And I think it's an area that will continue to evolve significantly, which is that you attack certain structures to maximize the effect for that structure.
And this may be a conversation for another time, but it's actually one of the big limitations I see with classification of pain. I mentioned this briefly at the beginning, which the most common classification people use at the moment is nociceptive, neuropathic, nociplastic. If you look at the classification of nociceptive pain, it basically says that you need to have pain that is reflective of being able to quantify a certain amount of tissue damage. And straight away, I actually see that as such a limitation because how many people, particularly in the general population, present with an insidious onset of pain that isn't associated with tissue structural damage? And based on the classification, you would say that person has nociplastic pain. And nociplastic pain is also then associated with experiencing pain patterns that are not like kind of your classic type of expectations of being localized or like referring in patterns that you wouldn't necessarily consider possible.
So the people listening, can you define each of those clearly? Because I think that we often don't necessarily have a strong indication of what they are, but you often get patients with differing pain patterns. So yeah, you mentioned nociplastic there. Can you explain exactly what that is?
Yeah, well, I'll just go through them. So we described neuropathic at the beginning. Nociceptive is pain generated from tissue outside of the neural tissue. So that can be related to muscle, connective tissue, bone. But like I said, it's typically an oversimplified classification because it's only pain when there's an ability to be able to quantify structural damage, which we've talked before, particularly when you think about the connective tissue system of you can see changes in the biomechanics. That's certainly associated with pain being generated as well. And then nociplastic pain is pain that's typically generated because of centrally mediated changes. And this goes down what we briefly mentioned before about thinking of things like central sensitization, which clearly is something that happens particularly with people with long-term pain. But some of the limitations I see with nociplastic pain is one, some of the definitions they give, because one of the definitions they give is if you're seeing changes in the location of pain, that's typically considered nociplastic pain. Yet, as we've talked about many times in this podcast, myofascial referral pain
can vary
massively and considerably from person to person, and even from within a person day to day, as your body compensates to try and maintain tensional balance within the soft tissue network. And it's one of the other big issues with nociplastic pain is, and I've actually had this experience myself, where I hurt my SIJ many years ago when I was doing a lot of weightlifting. I started to develop pain within my pelvic region. I thought I could manage it myself. Kept training, kept getting worsening symptoms, started getting like adductor type pain, started getting pain down through my lateral leg, started getting pain moving up my back. So again, when you think about the presentation of symptoms, it wasn't your classic type of nociceptive pain. But more importantly, I had it for years, and it actually started to like debilitate me also psychologically in ways because
that's not hard.
Yeah. Well, and when I think about it, I ended up actually seeing a physiotherapist who treated me and resolved all of my symptoms. And some of those centrally mediated changes, because of the fact that I had pain for years, also went away over time too. And when you think about it, of course that makes sense, because if you're getting a consistent bombardment of nociceptive pain because of irritation of tissue and because you aren't addressing some of the underlying factors with regards to the mechanics, the tissue capacity, the tissue quality, is it actually a surprise that you see changes at a central level when you think about...
Well, actually, here's a question for you, because I think about
long-term pain, yeah.
Are we too quick? And I think I know your answer to this, but Are we too quick to say that it's a centrally driven pain without necessarily understanding what peripheral tissue may be affected? And then we're not treating that peripheral tissue because we say, oh, well, you've had it for 12 months and therefore it's centrally, it sounds like it's centrally mediated. It's changing from position to position. It's not like it's not peripheral tissue. Do you think we're too quick to do that, and then we don't treat that peripheral tissue accordingly?
Look, absolutely. And I think this is where you have an issue with understanding that concept of the proximate versus the ultimate cause. Because obviously someone can present with 10 years history of low back pain with all the classic signs of central sensitization. But unless you actually go back and think of what happened 10 years ago, and that could be related to, oh, well, I actually had a particular traumatic incident, or it could be related to the fact that, as is very common with low back pain, there are certain mechanical factors that led to overloading or irritation of certain tissue structures in your back. And when you actually start to go down and think about, well, like what treatment have you had? What things do you actually identify from your objective assessment? You start to go on, well, hang on a second. I'm starting to see that this person actually has a lot of deficits in this basic tissue capacity around their back or through their hip or maybe their lower limb because they've had prior, knee injury or whatever it may be. What happens to their symptoms if I actually start to address these deficits over time? Because this is going to your point or to your question. If there are peripheral factors that haven't been addressed before and you do address them, over time, does that then start to change the mechanical loading of tissue that's becoming nociceptive? Does that then start to cause less nociceptive input to the central nervous system that then over time causes a reorganization of your brain and your central nervous system to restore, quote unquote, normal function. And like for me, clinically, the more I develop certain skill sets and that particular framework, I find that the ability to reverse centrally mediated changes with long-term pain seem to be very evident.
Well, it makes me think, as I said, that's why is there value in really understanding the pain generators in even if they're being centrally driven, but what the type of sort of presentation that they're providing gives people an indication to look for the treatment of other peripheral tissue. Because I think, as you said, if we just clump them all together and we think, oh yeah, that's coming from the back, that's related to that nerve root, and we're not seeing that, okay, maybe that's more dermatomal, or that maybe, as you said, sclerotome, or that one is actually more a fascia driven problem. We're not actually looking at what we can address there, because it's clear that if it's a different structure, there may be a different approach that's needed. And the reason that we've had this central, sensitization, as you said, is not necessarily that it's the centrally driven pain causing this bombardment. It's actually more of this periphery over time becoming so bombarded with this sensory input that it has to centralize, or at least those pathways become more entrenched.
Exactly. Like if you're getting constant input to the central nervous system of pain signals, I mean, of course you're going to get some centrally mediated changes. And I think that's probably where there's obviously been so much research into looking at chronic pain. And I think that's where we need to understand the value of understanding these centrally mediated changes, and particularly thinking about interventions that help to reinforce positive behavioral change, because something that's very clear that dependent on certain personality traits, people who are in pain, particularly long-term pain, will develop fear avoidant behavior and be less likely to participate in things like rehabilitation that may help their pain and also address some of the peripherally mediated factors. I think the issue is, it's like that point I made before. We see too much separation still within different subsystems in the body and the musculoskeletal system. And I think one of the really important things to remember here is that when we think about the nervous system and the peripheral system, which obviously includes part of the nervous system, they are constantly talking to each other. And it can also be the same way. Like for someone who does have certain personality traits where they catastrophize, they're really fear avoidant, they create changes that upregulate inflammation that then actually can also create peripheral changes as well. So that can be it's a bidirectional relationship for sure.
All right. Well, hopefully you've stimulated their appetite when it comes to this idea of understanding what generates pain, and potentially what features from even a centrally driven or pain or neuropathic pain. If you've got ideas on this, or you have further research that maybe we haven't seen, or you think that we're completely going down the wrong pathway, we obviously would love to chat with you. We think it's a really good opportunity to keep developing understanding and ideas. So, Jack, thank you for sharing what you've been exploring in some of your own research and clinical development.
Pleasure, John.